So I want to bring us back to why do we talking about pregnancy after SCAD? And really it's because the majority of patients that are affected by SCAD are women. We also know that SCAD is actually the number one cause of pregnancy-associated myocardial infarction. So really this has caused us to believe in the relationship that sex hormones are implicated as a cause or contributor to SCAD. Now, why is pregnancy a time of heightened vulnerability? And there's probably many reasons why this is. One is there's an arterial fragility that's just unique to pregnancies. The hormones that are released as a result of pregnancy, including one called relaxin that loosens up the pelvis to allow a loosening of the pelvic muscles to deliver the baby, that actually can have a negative effect on the arterial vasculature. There's also the hemodynamics of pregnancy. So we know that your cardiac output increases substantially during pregnancy. And there's also an arterial tree resistance from the gravid uterus pressing on the arteries that cause a resistance to the outflow of the heart. When we've done autopsy studies on healthy women who are pregnant who passed away in car accidents, when they did autopsy studies, there actually was an abnormality of the vasculature with loss of the normal corrugation or how the fibers link together and other changes that make the blood vessels more vulnerable to tearing. When you think about another dissection syndrome that occurs, aortic dissection, half of all aortic dissections in women actually under 40 are actually associated with pregnancy. And if there's a fourfold increased risk of aortic dissection during pregnancy compared to a similar time frame a year later. Again, similarly to SCAD, aortic dissection most often occurs in the third trimester and the first 3 months postpartum. And in the International Registry of Aortic Dissection, half of the patients actually had no known aortopathy or abnormality prior to their pregnancy. An additional mechanistic link to the pathophysiology of pregnancy is actually shown in Marfan's mice, where Dr. Dietz and colleagues from Hopkins took Marfan's mice, and the ones that they allowed to breastfeed had a much higher risk of aortic dissection compared to the moms where the pups were taken away at birth and were not permitted to breastfeed. We've already heard that SCAD is a more severe clinical presentation. You're more likely to have a STEMI, which is a larger type of heart attack, more likely to have multivessel involvement, and more likely to have LV systolic dysfunction or damage to your heart muscle as a result during pregnancy. So what data informs the safety of pregnancy after SCAD? Now, cardiologists are used to having millions of patients in randomized controlled trials to help inform how we best take care of our patients. And unfortunately, we don't have the luxury of that data in SCAD patient care. Dr. Tweet and colleagues from the Mayo Clinic did this lovely study where they looked at 636 patients at risk of childbearing, so reproductive age women, and they compared them to 92 patients who had recurrent SCAD, and then compared them to 158 matched controls. What they found is that the exposure of subsequent pregnancy actually did not increase the risk of SCAD. When you looked at the total cohort of 636 patients, about 15% of them had recurrent SCAD. And when they did the multivariate analysis, there was actually no relationship between association of subsequent pregnancy and recurrent SCAD. In a meta-analysis of, I think, several thousand patients, when they looked at a risk of recurrent SCAD, pregnancy actually did not pan out in this analysis to be a risk factor. And this, Dr. Grudzinski already showed this table, but you can see here, this is kind of the cumulative data we have just to point out that the total women with pregnancy after SCAD was only 59 patients across all of these studies. And the recurrence rate in this population was 6%. So pregnancy post-SCAD, yes or no? Bottom line is no in theory, but we realize as providers that this is really a very highly charged statement to make to our patients who are reproductive age women and really have their own plans for how they want to build their family. So in reality, it's more complex and context dependent. So in the absence of robust data, we have to really make this decision making should be guided by the nuances of each specific case or setting. So the way I'd like to propose a framework is that we look at each patient as individuals. So what are the patient-specific factors? Did the prior SCAD occur in the context of pregnancy? Does the patient have some sort of arteriopathy that makes them more likely to have a dissection? Did their heart function go back to normal, or do they still have some impairment of heart muscle function? We need to modify other pregnancy risk factors prior to conception, so weight, blood pressure management, etc. What is a care environment? Is there access to a tertiary coronary care center? And what are the patient priorities? The patients are such a part of this decision making, and everybody comes to the conversation with a different level of risk tolerance. So it's a shared decision making, considering alternatives if appropriate, such as surrogacy and adoption. If pregnancy is pursued, we need to optimize the patient prior to conception, including looking at all their meds, making sure their weight and their blood pressure are optimal. Define a monitoring plan during pregnancy, and there's no strong guidelines to actually inform what that looks like, but we should decide ahead of time, what is our plan if recurrent SCAD happens, what type of delivery, what's our delivery strategy, where is it going to happen, when is it going to happen, and what mode of delivery are we going to shoot for. And then postpartum is the critical time, because we need to make sure blood pressure is well controlled and that we have a very low threshold to investigate any symptoms. For one thing I want to stress to the providers that are listening to this presentation, if your patient has no pregnancy intent, it is on us as cardiology providers to make sure that there's a really good plan for contraceptive counseling. And we want to avoid the methods that have high failure rates, such as fertility awareness methods, that's using the calendar, barrier methods such as condoms, spermicide or withdrawal. These are not reliable methods, and we want to aim for reliable methods, and I prefer for my patients an IUD. So pregnancy post-SCAD, we generally do not recommend pregnancy post-SCAD as a standard guidance, but recurrent SCAD really can be devastating, and if desired, should really include a personalized risk assessment and a shared multidisciplinary team input. Thank you very much.